The following podcast is part of a certified educational activity titled Progress Meets Innovation in Head and Neck Cancer: Perspectives on Modern Immunotherapy and Novel Therapeutic Mechanisms. Access the entire activity and complete the post-test at peerview.com/NQB860. Downloadable slides and practice aids are also available.
Welcome everyone to our 4th annual Head and Neck Cancer Survivorship Symposium and our first one in person. So thank you all for being here today.
We want to welcome the more than 840 online registrants for today's event, as well as the 75
Thank you for sharing your story.
Great, thank you. So welcome everybody to our program on Progress Meets Innovation in Head and Neck Cancer. I'm Barbara Burtness. I'm a medical oncologist from Yale Cancer Center, and I have with me two very esteemed colleagues, Dr. Arti Bhatia, also from Yale, and Dr. Nabil Saba from the Winship Cancer Center at Emory. So just to set the stage, real-world data show progress in the management of recurrent metastatic head and neck cancer, but also some opportunities. So this is a retrospective cohort study from Flatiron, reported by Glenn Hanna. They looked at 1,879 patients who had recurrent metastatic head and neck cancer who initiated first-line systemic therapy between 2019 and 2022, and they had follow-up through 2023. And the questions had to do with uptake of pembrolizumab. So pembrolizumab, with or without chemotherapy, was the most widely used first-line option for recurrent metastatic disease. A little bit over 40% of patients received other first-line therapies. And in the second-line setting, 40% of patients received treatment, but actually it looked like nearly 50% had no subsequent lines of therapy. And then if you look at the breakdown, 33.5% with pembrolizumab monotherapy, Pembro plus platinum and 5-FU, 16%. Other platinum chemotherapy-based regimens, 8%. Platinum monotherapy, 15%. Platinum and a taxane, 8.6%. A nivolumab-based regimen, 6.7%. A cetuximab-based regimen, 5.7%. And other chemotherapy, 4.8%. So our goals for today, firstly, to improve your understanding of current guidelines and clinical evidence that support immunotherapy and novel therapeutics as part of the multimodal management of head and neck cancer in its different settings. To equip you with the skills you need to develop treatment plans that integrate checkpoint inhibitors and other innovative modalities into the management of head and neck cancer, and to provide you with guidance on managing practical aspects of care delivery, including patient counseling, proactive management of adverse events, and access to clinical trials. I want to call out again the Head and Neck Cancer Alliance. Their mission is to provide hope and support to individuals who are impacted by head and neck cancer, to raise awareness about prevention and early detection, and to advocate for improved patient outcomes. You can reach them at hello@headandneck.org, or you can scan that code that you see there. Their website is headandneck.org. You saw in the video some snapshots from their the Survivorship Symposium with really distinguished speakers like Sue Yam and May St. John. The event is going to be held in person and virtually this year on October 5th in Philadelphia, so please save the date. And then I just want to call out some of the programs that they offer. So Head and Neck Cancer Community is an online forum where patients can ask questions and get answers about the disease. They have a peer-to-peer mentorship program. financial assistance program, which includes the availability in some cases of a $50 gift card to head and neck cancer patients, which can help them pay for liquid nutrition or rides to the doctor, things like that. Free webinars during April, which is Head and Neck Cancer Awareness Month, a move-a-thon, and sponsoring a lot of head and neck cancer screenings, an ambassador program where survivors and caregivers can educate the public and help to raise awareness. So with that, I'd like to turn to talking about the modern role of checkpoint inhibitors as standards of care for recurrent metastatic head and neck cancer. And we thought we'd start with a case, a pretty common sort of scenario in our clinics. Robert is a 64-year-old man. He has a history of stage 3 laryngeal cancer, and he was treated for this in the definitive setting with concurrent chemoradiation using cisplatin. 2 years went by. He struggled with his recovery from the symptoms of chemoradiation, but was doing well. And then a chest CT showed bilateral lung nodules, the largest being 1.8 centimeters. He was asymptomatic. A biopsy was performed. This showed a P16 negative squamous cell carcinoma, quite consistent with his prior cancer. And the combined positive score testing for PD-L1 expression was 10. His performance status was 1. So now I want to turn to these experts here. And maybe I'll start with you, Nabil. What do you see as the options for this patient?
So this patient obviously has, first of all, I'm very happy to be here and glad to be with both of you, Barbara and Artie. This patient has a recurrent metastatic head and neck cancer. He's asymptomatic and has a CPS score of 10. So I think the evaluation will have to take into account the CPS score. As you very well know, the Keynote 048 essentially indicated that CPS more than 20 patients would basically benefit the most from single-agent pembro. CPS between 1 and 19. The consideration there is sometimes for single-agent pembro, but I think pembro chemo should be considered in that setting. I think in this situation, particularly because the patient is asymptomatic, even though the CPS is 10, I would be willing to consider with him outside of a clinical trial single-agent pembro. But I stand also to differ with others on this, given the data we just mentioned.
Artie, where would you come down?
So similar thoughts. Both pembro monotherapy and pembro plus chemotherapy are approved by the FDA based on Keynote 048 for patients who have PD-L1 CPS scores greater than 1. For someone who's asymptomatic, has relatively smaller lung metastases, has some room for progression if that happens on pembro monotherapy, where he can be rescued with chemotherapy, it wouldn't be unreasonable to consider pembro monotherapy. It is much better tolerated. It's got a better frequency of treatment than adding chemo. But yeah, your paper on the stratification of responses and survival based on CPS scores does seem to suggest that pembro plus chemo is also a reasonable option here.
Great, thank you. And you alluded to the greater safety of single-agent immunotherapy versus chemo-IO combo. And this patient is asymptomatic, so we don't have to say, well, what about the safety of not addressing his airway if he's got very bulky disease. Mm-hmm. I think that said, given the higher rate of progression for pembro mono in the 1 to 19 population, if you're going to end up needing to add chemo at the first scan at the 2-month mark, I think there's a case to be made for flipping it the other direction as well. But no head-to-head comparison, so we do not really know the answer.
If I may, Barbara, your data also on the second progressors, the second-time progressors, is very compelling in that when you start pembro, whether you're on the chemo pembro arm or the single arm pembro, these people do better down the line. So there's something to be said about an early initiation also of immunotherapy, whether with chemo or without chemo.
Yeah. Okay. Great. So to recap, I think you heard us, first of all, you didn't hear us say, but maybe this is an important point to make. Had this patient's PD-L1 been 50, we might not have spent as much time thinking about chemo. Had their PD-L1 been less than 1, I think probably I speak for all three of us that we would have not felt that pembrolizumab monotherapy was an appropriate standard of care. And in fact, I think at least at Yale, we probably would treat that patient with a pembro-free regimen and then save an immunotherapy for a clinical trial in the second line. It's important to assess clinical status. So each one of us thought about, is the patient symptomatic? Are they in pain? How's their airway doing? Are they breathing well? Because if they are symptomatic, the pembro chemo combination has a higher response rate. And then in a situation like this where there are multiple right answers, asking the patient's opinion, how does he feel about those extra side effects? And then closely monitor for immune-related adverse events during treatment. We wanted to highlight that immunotherapy is now a core part of the practice guidelines. So this is from the 2024 NCCN guidelines. And you see for first line, 2 options that are category 1 that involve pembrolizumab, either pembrolizumab together with combination chemotherapy or pembrolizumab alone for tumors that express PD-L1. And then you'll see there's still a category 1 for cetuximab, platinum and 5-FU, which was the comparator arm in these randomized studies we'll be talking about, because for the patients with PD-L1 less than 1, that regimen was superior. So what are the data? How did we get here? The first trial that enrolled a substantial number of head and neck cancer patients to get immunotherapy was KEYNOTE-012. This was an expansion cohort or a phase 1b trial, a number of different diseases, but a big cohort of head and neck cancer patients, equal numbers of HPV positive and HPV negative who got pembrolizumab monotherapy. And this study, I think, is notable, firstly, for the first FDA approval of an immunotherapy, and second of all, for leading to the recognition that PD-L1 could serve as a biomarker. Then we had Checkmate 141, the first randomized study, and this established that nivolumab, as compared to investigator's choice with a taxane, methotrexate, or cetuximab for platinum refractory patients, that nivolumab was superior. And platinum refractory was defined as either progression on platinum therapy or within 6 months of the most recent platinum-based therapy. And then KEYNOTE-040, very similar design, a little bit of a different study in that it was still running after these drugs became commercially approved, so there was more crossover, but once again validated pembrolizumab in the treatment of patients who had platinum refractory disease. And then KEYNOTE-048, which established pembrolizumab in the frontline setting as a single agent or in combination with platinum chemotherapy. And just to show you these data, this is long-term follow-up now that was showed by Dr. Tahara at ESMO in 2022. And so you can see we now have 5-year results. And on the left, you see the patients who were treated with pembrolizumab monotherapy compared to the extreme regimen of chemotherapy and cetuximab. And you can see that the median survival went from 10.4 months with the extreme regimen to 12.3 with pembrolizumab, hazard ratio of 0.74, highly statistically significant. But then if you look at the 60-month follow-up results, extreme, 5.5% of patients still alive. That's pretty much in line with all of our prior experience with that regimen. And then the use of pembrolizumab monotherapy, 15.4% of patients alive at 5 years, not something we had previously seen in this disease. And then for the same population, CPS 1 or greater, pembrolizumab plus chemotherapy, the median went from 10.6 to 13.6, hazard ratio here 0.65. And here you see the 5-year result going from 4.3 to 18.2%. If you look at the CPS 20 population, and this is about 45% of the patients that we see with recurrent metastatic disease, here, again, the pembrolizumab approaches were better than the non-pembrolizumab approaches. So median survival for CPS 20, pembrolizumab alone, 14.9 months over 10.8 with the extreme regimen. And then pembro plus chemotherapy, 14.7 months compared to 11.1 for the extreme. So those hazard ratios, both just a little above 0.6. But then if you look at the long-term results, 60-month survival, went from 7.4 to 19.9% for pembrolizumab monotherapy and from 6.4 to 23.9% for pembrolizumab plus chemotherapy. RT alluded earlier to the subgroup analysis by combined positive score. So this looks at either pembrolizumab alone, which is up top, or pembrolizumab plus chemotherapy, which is down below. And then on the left, you have the 15% of patients who have CPS less than 1. And on the other side, you have the group of patients who have CPS 1 to 19, which was nearly as big a population as the CPS 20 population that was actually one of the powered analyses in the study. The CPS less than 1 was a pretty small number of patients, and I think it's important to caution everybody these were not prospectively planned subset analyses, and they are a bit small. Nonetheless, I think that they're instructive, and if you look at CPS less than 1, pembrolizumab, that survival curve is below cetuximab and chemotherapy all the way along. If you look at the CPS 1 to 19, the 12-month proportion of patients surviving is equivalent. The medians were quite similar. There does seem to be a little bit better tail on the curve for pembrolizumab. If you go to pembro plus chemo, CPS less than 1, no difference in 12-month, no statistically significant difference between those curves. But if you look at the 1 to 19, here you start to see pembro plus chemo really emerging above the cetuximab plus chemotherapy with a median survival of 12.7 months. We also just wanted to, and this addresses a question actually that came in on from somebody submitted through the tablet here. How does P16 status influence your choice of first-line therapy? And so just to tease out from the Keynote-048 trial, those patients who had P16 positive versus negative disease, if you look at the CPS, and the top is pembro chemo, and the bottom is pembro monotherapy. And so if you look at the CPS 1 or greater, you see the pembro compared to the cetuximab regimen had a hazard ratio of 0.64 for the P16 positive, and then in the CPS 20 group, which however was a smaller number of patients, 0.72. But then if you went to the chemo arms, here the hazard ratios really emerged as somewhat more dramatic for the P16 positive. So CPS 1 or greater, hazard ratio of 0.55. And then if you look at the CPS 20, hazard ratio of 0.39. And that was actually the strongest effect across all of the subset analyses in the forest plot on that paper. So let's turn now to the question of, is there anything we could do to optimize this upfront regimen? And the first thing that I'll say is if you get 10 medical oncologists who do a lot of head and neck cancer into a room, you can get them to argue for hours about, platinum versus carbo with radiation, or treatment de-intensification in the post-op setting, but you will never get anybody to argue that they love 5-FU, right? Like everybody will say that platinum 5-FU regimen, the 4 days with the pump, the mucositis, why do we have to do that to our patients? And so this is something that's been addressed in a couple of single-arm studies. Firstly, looking at pembrolizumab, carboplatin, and paclitaxel. Does this represent an alternative immunochemotherapy option? So there was a phase 4 study called the Keynote B10. This was presented at ESMO, I think 2 years ago. And this suggested that a 5-FU-free combination can be an alternative. So you see there were 82 patients in this analysis. The objective response rate was nearly 43%, the complete response rate about 5%, and the number of patients with early progression was under 20%. The proportion with disease control, 58.5%, and you see here the duration of response, 5.5 months. The drug exposure is shown here, so a high proportion of patients were on this for a goodly duration with more than 7 cycles of pembrolizumab. And you can see that paclitaxel, over half of patients got at least 5 cycles. In terms of toxicity, neutrophil count decreased was the most common thing, followed by anemia and fatigue. All of this, I think quite similar to what was seen in Keynote-048, but with less GI toxicity and less mucositis. So the safety profile of pembrolizumab, carboplatin, and paclitaxel was consistent with the known safety profiles of all of the drugs. And then from Gore-Tec, we saw the Frail Immune trial, which took the PD-L1 inhibitor durvalumab, not actually FDA approved in head and neck cancer, but a drug with some activity, and added this to weekly carboplatin and paclitaxel in patients who were either elderly or had some comorbidity. And here they got 4 cycles of chemotherapy together with durvalumab, followed by durvalumab alone. 2-year survival was 45% for these patients. So I think the increasing comfort with using a taxane-based regimen for patients where you want to avoid the toxicity of an infusion pump. And then the other approach, obviously, would be to add different classes of drugs. And so what about tyrosine kinase inhibitors and vaccines? So he looked at the multi-targeted kinase inhibitor cabozantinib, which has known anti-angiogenic effects, and both through its anti-angiogenic effects as well as through some of its other molecular targets, is known to have a beneficial effect on macrophage polarization, so decreasing the immunosuppressive nature of the tumor microenvironment. This was a phase 2 trial of pembrolizumab combined with cabozantinib, 33 patients with recurrent and metastatic head and neck carcinoma, objective response rate of 52%, and early progressors under 10%. And you see the waterfall plot there, some pretty deep responses in both HPV positive and HPV negative patients. We saw at the Scottsdale Head and Neck meeting this year the results from a randomized trial called LEAP-10, which was combination therapy of a different multi-targeted kinase inhibitor, lenvatinib, a potent anti-angiogenic agent, together with pembrolizumab. And this study had been mounted because of a response rate in the 40% range shown with this combination in a single-arm trial. So here, patients who had recurrent metastatic disease, PD-L1 expression, and no excessive risk of bleeding, so no hemoptysis, no tumor involving a vessel, were randomized between placebo pembrolizumab or lenvatinib pembrolizumab. And in many ways, this looked like an extremely active regimen with, as you can see here, a dramatic impact on progression-free survival, taking progression-free survival from 2.8 to 7 months with a hazard ratio of 0.68. And you can see that at 15 months, you still had over a quarter of the patients non-progressing. However, this did not translate to a survival advantage. So you can see that the OS at the second interim analysis was 15 months for lenvatinib pembro and 17.9 months for pembro plus placebo. So one of the first things that I think people asked was, well, how come pembro plus placebo did so great? And I think, I have 2 hypotheses. One is there was pretty strict patient selection to get on this study because of the possibility of bleeding from lenvatinib. So maybe some of the patients with the bulkiest disease were excluded. I also think because the control arm was pembro plus placebo, those patients that we were alluding to before who are short of breath or in a lot of pain or have an airway issue, those patients may have been more steered to a chemotherapy, immunotherapy combination off study. So this may have been a more selected population. So I think no question there's a very strong signal for this combination, but it appears that if you give it in a chemo-free setting in first line and the patients are able to cross over to something else, that it's difficult to get an overall survival benefit here. So we'll stay tuned for the second-line data. Nabil is chairing a phase 2-3 study with zanzalintinib, which is a cabozantinib analog now in development. And this will be added to pembrolizumab compared with pembrolizumab alone. This has very similar targets to cabozantinib, and the design of the study is a primary endpoint of progression-free survival and a dual primary endpoint of overall survival.
It's actually phase 2 getting to PFS, and then
phase 3 is the OS endpoint. Yep, got it. There's also a lot of interest in what can we do to enhance antigen diversity presentation in head and neck cancer to improve the benefit of immunotherapy. So I wanted to highlight this mRNA product 4157 or V940. It's a novel investigational RNA-based personalized cancer vaccine So it's a single synthetic messenger RNA coding for up to 34 neoantigens. So they obtain a tissue sample from the patient, sequence it to identify the mutations that are predicted to be neoantigenic. The neoantigen therapy design is an individualized mRNA that codes for those mutations, and then they manufacture one lot per patient. And so this is being given in a randomized trial of pembrolizumab plus the product, followed by with an efficacy endpoint. In a small early experience of 22 patients, this appeared to be both active and tolerable. So you can see in the spider plot there, there was a patient with a complete response, a number of deep responses that seemed to go on for approaching a year. The overall objective response rate was 27.3%. Disease control was 63.6%. And as you see, treatment emergent adverse events, although there was an influenza-like response to this, as with many vaccines, there were no grade 3 or higher influenza-like events. There was one case of high-grade pyrexia, one of lipase increase. So that looks like a very intriguing strategy. I also wanted to highlight the IO Biotech twin cancer vaccines. So this is a cancer vaccine directed both against IDO and PD-1 and given together with pembrolizumab. I think people will remember a few years ago there were a couple of IDO inhibitors that were in development, and we were very enthusiastic about that direction in head and neck cancer because IDO had been linked to immunotherapy refractoriness, and we knew that head and neck cancer was a very IDO-rich cancer. Those trials failed or closed early. The large phase 3 studies in melanoma were not successful. This is a different strategy. This is a strategy that says, well, IDO might be difficult to target, but we know that it's there. So it's something that's part of the cancer address. And so creating a vaccine against it may enhance immune response. So this combination study is being done as a neoadjuvant design. So patients get 2 to 3 cycles of the vaccine together with pembrolizumab, go to surgery. If they have it's both for melanoma and head and neck cancer. If they have a head and neck cancer, they get appropriate risk-based postoperative therapy, and then they go back on the vaccine. Just want to take a couple of minutes now to turn to nasopharynx cancer, where immunotherapy is also having a major impact. So we'll start with Linda, a 40-year-old woman who has an EBV-associated nasopharynx cancer, T2N2M0. She's previously had gemcitabine and cisplatin induction chemotherapy, followed by chemoradiation. And she finishes her chemoradiation, but then she's found to have a 1.5 centimeter liver lesion. And so, Arti, what would you do? Would you take the patient to surgery? Would you put them back on systemic therapy? And what would that look like?
So nasopharynx is a very systemic disease. And, even for patients with small volume metastatic disease, I favor putting back on systemic treatment. And last year, the fall time, the FDA approved toripalimab in addition to platinum and gemcitabine in the first-line setting for treatment of recurrent metastatic disease. So that's what I would choose for this patient.
I think particularly with the short interval follow-up, you have to worry what else is going to pop up, Nabila. Yeah, okay. So our recommendations for this patient would be toripalimab plus chemotherapy. If the patient comes to you and has already had gemcitabine cisplatin as their first-line therapy and are now progressing, based on the Polaris trial, you can also offer second-line toripalimab. And as with any immune checkpoint inhibitor, vigilance for immune-related adverse events. So here are the NCCN guidelines for nasopharynx cancer. First-line therapy, now category 1, gemcitabine, cisplatin, and toripalimab. And then for institutions where tori might not be on the formulary yet, the NCCN gives you kind of a backdoor cisplatin, gemcitabine, plus other PD-1 inhibitor. Here are the JUPITER-2 data that Arti was just referring to. So you see here that the addition of toripalimab to gemcitabine cisplatin improved progression-free survival from 8.2 to 21.4 months. with a hazard ratio of 0.52, and you see nice durability to that effect. If you looked across patient subgroups, whether you were looking at age, gender, ECOG performance status, baseline recurrent versus metastatic disease, high or low EBV copy number, and PD-L1 expression, which here was done by tumor cells, the addition of toripalimab was helpful in all groups. We've now seen the final overall survival analysis of this trial with a median follow-up of 30 months, showing a significant improvement in overall survival for the addition of toripalimab with a hazard ratio of 0.63 and a p-value of 0.083, and median overall survival not reached in the toripalimab arm compared to 33.7 months in the control arm. No new safety signals were seen. And we also have seen proof of concept with a substantial PFS improvement with the addition of an alternate PD-1 inhibitor tislelizumab to chemotherapy in the Rationale 309 study. We can look at our summary and take-home thoughts for this section. First-line immunotherapy plus combination chemotherapy now represents first-line standard of care, both for virally associated and non-virally associated head and neck cancers. And with the caveat that for mucosal head and neck cancers that are not of the nasopharynx, that should be guided by PD-L1 expression. And toripalimab plus gemcitabine cisplatin is now the standard of care in the recurrent metastatic setting for nasopharynx cancer. Multiple trials are testing ways to optimize and enhance immunotherapy in head and neck cancer, including combinations with anti-angiogenics, multi-targeted tyrosine kinase inhibitors, and vaccines, and I really urge you to think about these for your patients. So with that, I'm really delighted to turn this over to Arti Bhatia to talk about emerging targeted platforms and newer mechanisms.
Thank you, Barbara.
Thank you.
So good evening, everyone, and thank you for the opportunity to have me present here. I will be reviewing emerging targeted therapies in head and neck cancers. So let's start with the patient scenario 2. Mark is a 56-year-old male, former 30-pack year smoker, was initially diagnosed with a stage 4A P16 negative gingival squamous cell cancer. And he was treated curatively with surgery followed by adjuvant chemoradiation, but unfortunately progressed 4 months later with lung metastases. The biopsy confirmed, again, P16 negative squamous cell cancer consistent with his initial primary. PD-L1 CPS was 10. Given that he had asymptomatic small volume disease, he was treated with pembrolizumab monotherapy. He progressed through that 8 months later and was rechallenged with chemo. He got platinum 5-FU and cetuximab. Initially responded, but again progressed through that 6 months later. He still has a good performance status, is keen to try more treatment. So, at this point, I'd like to involve our expert panel. Nabil, what do you think are subsequent lines of treatment options for him?
Yeah, I think let me first start by saying there is no clear standard in this patient population, which is really why what we mentioned earlier is we need more clinical trials to be able to decide what to do for these second-line, third-line patients, because we really are desperate for this. So, this is a little bit of a dilemma because he already had cetuximab. Mm-hmm. And if he did not have cetuximab, I would have thought, could we do a combination of immunotherapy plus cetuximab? Mm-hmm. Because there is data showing that the combination, specifically in HPV negative disease, which basically applies here, could be potentially valuable. 2 studies here were done, pembrolizumab, cetuximab by Ezra Cohen and Tina Sacco at UCSD, and then another study by Christine Chung with nivolumab and cetuximab. And so I think that could have been an option. In this situation, I think outside of a clinical trial, I would try to think of something along the lines of VEGF, for example. I don't know if I could get this approved through his insurance, but you're back to the drawing board. You're back to essentially trying either, another agent, for example, a taxane-based therapy, or back to the investigator's choice. But so I think we really need clinical trials here. I don't know. That would be my answer.
No, so we're hearing that, no good standard options here. Barbara, do you feel like, since having patients treated with immunotherapy, we're seeing more and more patients who qualify maybe for third line and beyond treatments and need better options in that population?
For sure. I think, firstly, we know from the retrospective work from the Curie Institute in Paris and then from the PFS2 analysis from Keynote-048 that the benefit of chemotherapy in subsequent lines of therapy is greater than it had been historically in the pre-IO era. But I have to say, I think every patient deserves a crack at a taxane if they're eligible. This patient has never had a taxane. Yeah, I mean, I think you might want to say to the patient, let's look for a clinical trial now because you're still eligible for one, and who knows, what taxanes might do in terms of your counts. You're heavily pretreated, you might not be eligible down the road. But I do think that a single agent taxane in a post-IO patient remains a very, very potent strategy, and I would not want to have the patient not have that option at some point.
Thank you. Thank you both for that discussion. So just to summarize what we talked about, current standard of care options for this patient include taxanes. You could also consider methotrexate, afatinib. Those are listed in the NCCN guidelines as options for third line and beyond therapy. But, we do know that patients in the immunotherapy era are living longer. So single agent responses with these agents are going to be low, maybe even less than 15%. And we do need better options, newer therapies with better responses for this population. So I will be reviewing the current literature for newer EGFR-directed therapies, bispecific antibodies, antibody-drug conjugates, as well as HPV targeting therapies for these patients. So we know that cetuximab remains the only FDA-approved targeted therapy for this disease, but its clinical utility is really limited. There's multiple resistance mechanisms, including dimerization with other members of the HER family, crosstalk with other receptor tyrosine kinases like CMET, and that just limits its single-agent response rates to less than 15%. Multiple strategies have been tried to overcome these resistance mechanisms, particularly targeting the MET pathway. And we'll be talking about that a little bit here. So CMET is a transmembrane receptor tyrosine kinase, and it's ligand bound by the hepatocyte growth factor, or HGF, whose pre-active form pro-HGF is selected by the local tumor-associated fibroblasts. And once it's ligand bound, there is downstream oncogenic signaling through GRB2, GAB1, and those further recruit other proteins and pathways like the RAS-RAF pathway, STAT3, SHP2, ultimately all leading to tumor cell proliferation, invasion, and metastases. And multiple drugs are in clinical development and investigation trying to target this pathway and prevent this downstream cascade. These include ficlatuzumab, which is a monoclonal antibody against HGF. There's also onartuzumab, which is an antibody against CMET, and crizotinib, which is a tyrosine kinase inhibitor for CMET. So in a phase 2 trial, 60 patients with recurrent metastatic head and neck cancer that were refractory to platinum, cetuximab, and anti-PD-1, so all standard therapies, were randomized in a 1:1 fashion to either ficlatuzumab monotherapy or in combination with cetuximab. The primary endpoint was median progression-free survival, and the response assessments were stratified by HPV status. The ficlatuzumab monotherapy arm closed early because it met futility criteria, but the combination arm had a median progression-free survival of 3.7 months, which met the protocol-specified criteria to move to a phase 3 study. And the median overall survival for the cohort was 7.4 months. The last Kaplan-Meier curve shows the PFS stratified by HPV status, and there is a clear separation of the curves, which the HPV-negative population doing better. The median PFS was 2.3 months for the HPV-positive subgroup, which essentially meant progression at the first scan. But for the HPV-negative group, it was 4.1 months. And all the responses, important to see here, all the partial and complete responses were seen in the HPV-negative subset. So that subset had a response rate of 38%, and this is a pan-refractory tumor subset. And in the HPV-positive group, there were no responses. The most common side effects with the combination arm were acneiform rash, which is a known class effect of EGFR inhibitors, hypoalbuminemia, edema, and 3 cases of pneumonitis were also reported, which is a rare but known class effect with HGF and MET inhibition. So based on the results of this trial, FIERCE-HN is a randomized phase 3 trial that is currently enrolling in patients with HPV-negative disease because all the responses were in that group. This will enroll patients that are refractory to platinum-based chemo and anti-PD-1 therapy, but have to be cetuximab naive. This is a 3-arm randomization to cetuximab plus placebo or cetuximab plus ficlatuzumab, and 2 different dose levels of ficlatuzumab are being evaluated for optimal dosing. And the primary endpoint is overall survival. Next, I'd like to talk a little bit about some of the newer bispecific antibodies and ADCs that are in development in head and neck cancer. So petosemtamab is a bispecific antibody targeting EGFR and LGR5 in cancer stem cells. In preclinical models, binding with this drug led to degradation of the EGFR receptor, and it has a dual mechanism of action by directly blocking the growth and survival pathways of cancer stem cells, and also recruiting immune cells in an ADCC type of action to kill the LGR5 and EGFR expressing cancer stem cells. And it showed very potent anti-tumor activity in xenograft models of head and neck cancer tumor types. So this was results from the dose expansion cohort in head and neck cancer that was presented at AACR last year. 49 patients were enrolled. These patients had, again, pan-refractory disease, including 2 anti-PD-1 agents, platinum-based treatment, and cetuximab. They received the recommended phase 2 dose of peto at 1,500 milligrams IV Q2 weeks, and the primary endpoint was overall response rates. And this is the waterfall plot for response. The investigator-assessed response rate was 37%. The disease control rate was 72%. And this compares very favorably to what we are used to seeing with cetuximab monotherapy, where the response rates are less than 15%. One patient, the extreme right bar, had a complete response, and one patient with HPV-positive disease also had a response. And treatment was ongoing for 10 patients at the time of this presentation. The median duration of response was 6 months, but again, this number is going to change as data mature. 2/3 of the responders were on treatment at the time of this presentation. Median PFS for the cohort was 5.3 months, and the median overall survival was almost a year. And again, that number might go up as the data matures because over half the patients were alive at data cutoff. The safety profile was pretty consistent with what you would expect with EGFR targeting. So rash, acneiform dermatitis were reported. Hypomagnesemia was a frequent AE, as were infusion-related reactions. And probably more of slightly higher grade infusion-related reactions with this agent. They reported it in about 13% of patients than you would expect to see with single-agent cetuximab. This trial, the petosemtamab and pembrolizumab trial, is also going to be opening in a first-line setting as a randomized study. Next up is MRG-003, which is an antibody-drug conjugate. It utilizes a humanized IgG1 antibody against EGFR, which is conjugated to monomethyl auristatin, which is a microtubule inhibitor. And once the agent binds to EGFR on the tumor cell, the drug gets internalized, transported to the lysosome where the linker is cleaved, and active monomethyl auristatin, which is the payload, diffuses out as a free drug to kill that tumor cell as well as bystander tumor cells. So this drug was explored in a phase 1 trial in multiple tumor types, including head and neck cancer, nasopharynx cancer, and colorectal cancer. And subsequently, there was a phase 2 study in recurrent metastatic nasopharynx cancer patients. These patients were refractory to anti-PD-1 therapy as well as to platinum-based therapy. 2 different dose levels were explored in the nasopharynx group, the 2 mg per kg and the 2.3 mg per kg, and the primary endpoint was objective response rate. So these were results from their phase 1 study. 39 patients with head and neck, nasopharynx, and colorectal cancer were enrolled, and the response rate was 40%, 44%, and 0% respectively for those 3 cohorts. The median duration of response was 5.6 months for head and neck cancers. It wasn't reached for nasopharynx, and the median overall survival was almost a year for the head and neck cohort. Most side effects were low grade. The commonest was rash and AST elevation. And this was the phase 2 study in nasopharynx cancer that was presented at ESMO last year. So I think it was the 2 dose cohorts had 28 and 29 evaluable patients. Response rates were 39% in the lower dose and 55% in the higher dose. So very exciting response rates for late-line nasopharynx cancer treatment. The median duration of response was about 7 months in both these cohorts. So this drug is likely going to be explored in a late phase trial too, utilizing probably the higher dose. Next up is BCA-101. This is a bispecific antibody that targets EGFR and TGF-beta. And it localizes TGF-beta inhibition to the tumor microenvironment because it's using an EGFR-directed approach, which should, in theory, target the tumor cells. It exerts its anti-tumor activity by enhancing ADCC and NK cell engagement. It also prevents mesenchymal transition and metastases. And this drug was assessed in a phase 1 trial first in multiple tumor types, including head and neck cancer. And results from the head and neck cancer cohort, where it was used in treatment-naive patients, first-line recurrent metastatic setting, these patients had CPS PD-L1 1 or greater scores, and that cohort was treated in combination with pembrolizumab, and the results were presented at ASCO last year. So this was the 39-patient cohort treated with pembro and BCA-101. The response rates for the entire cohort was 46%, but in the HPV-negative cohort was about 57%. Most side effects were, again, with EGFR targeting, so skin toxicity, dermatitis, acneiform rash. There were some mucosal bleeding events. These were generally low grade, did not require dose interruptions. And this combination is also going to be explored in HPV-negative patients in the first-line setting. Tisotumab vedotin is another antibody-drug conjugate. It targets tissue factor, and it's being looked at in multiple tumor types, including head and neck cancer. This is already FDA-approved for recurrent metastatic cervical cancer as well. And it's being looked at in many tumor types where tissue factor is highly expressed. This was looked at in a phase 2 trial in, again, pan-refractory patients. The results were presented at AACR last year. And this is the waterfall plot. So a 40% response rate was reported. Again, remember, these patients had no standard treatment options. The median progression-free survival was about 4.5 months. And the most common adverse events were asthenia, neuropathy, vomiting, and conjunctivitis. And lastly, I'm going to talk about treatments that are targeting HPV. We know that this is a biologically distinct subset of head and neck cancers. And over the past few years, many trials have focused on targeted therapies against HPV-specific oncoproteins. So the first step is Q101, which is the first immunostat in clinical trials. And immunostats are fusion proteins. So they aim to locally deliver cytokines into the tumor microenvironment to enhance and activate tumor antigen-specific T-cell responses. So this drug has an HLA complex that will deliver an HPV-16E7 peptide epitope to the immune cells. And there's also 4 molecules, the 4 hexagons in purple, of humanized IL-2. And the goal, again, is to bind, expand, and activate tumor antigen-specific T cells. So this was presented at ASCO last year. This was the swimmer's plot for overall survival with the monotherapy, so just the Q101 agent in patients with HPV-16 positive disease. And this group had an overall response rate of 22.4 months. This was in 20 patients. This was a cohort of 14 patients that were treated with a combination of pembrolizumab and Q101 in the first-line setting. A response rate of 36% was reported. All 4 out of the 5 responses occurred in patients with PD-L1 low scores. And this is the swimmer's plot for survival, again, in patients who were treated with a combination. There was a median progression-free survival of 5 months. And this is PDS-0101. It's another HPV-directed therapy. It works by upregulating interferon, promoting antigen processing, cross-presentation, and really stimulating a targeted T-cell response against HPV-16-driven cancers. Versatile-002 was explored a combination of pembrolizumab and this agent in treatment-naive, recurrent metastatic HPV-16 positive and PD-L1 positive head and neck cancers. Last year at ASCO, they presented a median PFS of 10.4 months, which is vastly different from the 2 to 3 month PFS that we know is what we see with pembrolizumab monotherapy in this population. And at a press release last month, the company announced an updated response rate of 34%, and they had reported a median overall survival of 30 months, also very different from what we know about in these patients. So this agent is going to be explored in a phase 3 trial as well. Okay, and just to summarize the key points from this section, so newer targeted strategies targeting EGFR, antibody-drug conjugates, and bispecific antibodies are really showing some preliminary promise and improving responses in the pan-refractory patient. HPV targeting therapies are another very exciting area of research for patients with HPV-driven malignancies. Many of these molecules are going to be presenting very exciting updates in the coming days at ASCO, so I hope you all can attend and learn more. Thank you.
Okay, and now we're going to turn it over to Nabil Saba.
Well, it's my pleasure to follow my two very esteemed colleagues here. And in the next section, I think we're going to switch gears a little bit and try to talk more about how to position immunotherapy in the definitive setting, because I think this is really our next venture, if you like, and something that we need to really work very hard on. And I'll show you some disappointing data, and I'll show you also some ideas that you need to probably elaborate on in the future. So as the previous speakers mentioned, let's start with a case presentation to set the stage for this discussion. So here you have Sarah, who is a 45-year-old actor who presents to you with a progressively enlarging left lung mass and a large neck node. She is staged in the clinic as having a T4A N3, and as you know, this is a very bulky disease, HPV unrelated disease. The CPS score is 24. She does not have metastatic disease, just to clarify that. She is deemed by our surgical colleagues to have a resectable disease. I'm not sure if anyone from our surgeons at least would say unresectable for any of these patients, but I think just to go back to the case, so she has resectable disease. The sequelae of resection, of course, you can imagine is going to be pretty morbid for this patient. She would require a total glossectomy, which means that she would not be able to function as an actor, certainly at her age, and she will require, of course, reconstructive surgery. We know that this is one of the approved treatments, certainly the standard approach. However, she's in your clinic, you're in the era of immunotherapy, data from other tumor types, we know the data in lung cancer, we know the data in other diseases where immunotherapy may have a role in the pre-op setting, not so much in head and neck cancer. So let's start with Dr. Bhatia. What would you think? Let's start with two portions of the question. So one portion would be, let's say you did not have immunotherapy available. You're in the pre-immunotherapy era. Would there be any other option for this patient, you think?
So you mentioned, Nabil, and I'd like to just stress that you first want to consider surgery. That is the standard of care. There is a clear survival benefit. But of course, in some patients, especially younger patients who were facing the prospect of a very morbid outcome from surgery, they may decline to pursue that option. And prior to the era of immunotherapy, I think we used to offer, either chemoradiation or induction chemo followed by chemoradiation as an alternative. I have personally done that for a few patients as well. And we have actually managed to cure some patients with that strategy. So it's definitely a viable option.
Great. And then going back to Dr. Burtness with the question, we live in the current era of immunotherapy. First, your comments, if anything, on Dr. Bhatia's impression, but also in the immunotherapy era, what would be your best approach for this patient?
Yeah, I mean, I think that there's no question that there are retrospective and population data-based reports that indicate that surgery would be better than chemoradiation. And I think that that's believable because we know CR rates are lower for the bulkiest cancers. On the other hand, I do think it's important to say that there has never been a head-to-head comparison, and often the patients who end up getting chemoradiation are either not fit for surgery or, their choice to reject surgery might indicate less social support or, So I think that we all believe that surgery is the right step. I'm not sure it's ever really been proven. But for a CPS 24 patient who's a young working actor who needs her tongue, I do think that we can honestly say to patients that there are some patients who, when they get neoadjuvant immunotherapy, have very meaningful responses. And I think that we can also say that we know that in the completely treatment-naive person where the lymph nodes have not been ablated or dissected out, that the response rates to chemotherapy and IO combination are higher than, for example, we saw in the pembro chemo arm of KEYNOTE-048. And there are now experiences we heard last year at ASCO from the MD Anderson group, their larynx preservation strategy. And I think that we also have from a number of studies, the Ravio Belluri study, the Trush-Wise-Draper study, the MD Anderson study that I mentioned, reassuring evidence that in the PD-L1 positive patient, the number of people who are going to progress and lose their chance at resection is not high, 2% maybe. And so we have neoadjuvant trials at my institution. I'd talk to her about those. If she wasn't eligible, I don't think I would feel immoral giving her chemo IO.
Yes, and I have to admit, and I think probably the three of us, if I may say, would agree with this approach. And this is, as a matter of fact, a patient who was seen at our institution, and this is exactly what we proceeded with. She proceeded to have her surgery after 3 cycles of Taxol carbo-pembro and had a complete pathologic response. Preserved her tongue, was very ecstatic, of course, but, I'm not going to say the rest of the story, but she's struggling a little bit, but I think achieving a complete pathologic response and preserving your tongue, I'm sure everyone agrees, is an achievement already. And I think we talked about the other options. So let's move on with the discussion. So as a tumor board recap, we're going to say recommendations for this patient with resectable is we agree the current standard of care is still surgery and adjuvant therapy, that radiation and chemotherapy may be also an option based on small series at the University of Chicago. And I think at Fox Chase, there has been some experience with this as well. But there's increasing mounting evidence, as we will see in the next minutes, that neoadjuvant therapy in this patient is certainly a plausible approach based on piling data in other tumor types, but also in lung and head and neck cancers, as I would show you. So Dr. Burtness alluded to the larynx preservation trial that was performed and reported last year at ASCO. And this trial used chemoimmunotherapy as well, platinum, cisplatin docetaxel, and pembrolizumab for 2 cycles. And for patients who had disease progression, they went on to receive definitive therapy, meaning either radiation, depending on the stage of their disease, or laryngectomy, if this was not deemed to be a larynx that is worth preserving. However, if they did have stable disease or a response, they went on to receive 2 additional cycles, and then they were followed closely. And so I'm not showing this trial to say that this should be the standard. This, of course, is a small study. However, it's a proof of principle in the sense that you did not lose patients to progression of disease. You did not basically have an unsafe approach to treatment. You had a survival rate of 95.8%. The patients who had recurrence were 2 out of the 24. And so I think this is pretty encouraging data. Of course, this is a single-arm trial. To be able to move this to standard therapy, we probably need a larger study. I'm not sure how we would randomize to such a trial, but I think it is certainly something that to keep in mind, and this is an example of such a trial. But over the next few minutes, I'm going to give you the story of what we have witnessed over the last basically 7 years or so with trying to advance the field in locally advanced head and neck cancer with the advent of immunotherapy. Dr. Burtness talked to us extensively about recurrent metastatic disease and how we were all excited about these agents. When we saw the results for the first time in the history of treating head and neck cancer, we saw a survival curve that showed improvement in survival. But then because of this excitement, I think everyone was in a rush to see what would happen in the locally advanced disease. So we decided to pretty much pile up these agents onto the current standard of care, which we now know probably is not a very wise approach. And the first big disappointment was when we added avelumab, which is a PD-L1 inhibitor, to the backbone of cisplatin full dose at 100 milligrams per meter squared every 3 weeks for patients with locally advanced disease. And, you know, there has been a lot of discussions about the fact that avelumab is a PD-L1, whether the approved agents are PD-1. But there is more to this. I mean, this is basically the avelumab arm, and this is the placebo arm. So there's something, it seems, from Javelin, something somewhat detrimental by adding these to adding a PD-L1 or PD-1 inhibitor to the backbone of concurrent therapy. And so moving on, fast forward to just this, before we move on. So I think one of the main reasons is something that Barbara alluded to, which is that the immune system around the tumor, mainly the draining lymph nodes, play a major role in potentiating the immune activity against the tumor. And so when we bank on these immunotherapeutic agents, at least in animal models, and now we know from studies that were done in multiple settings, including Sana Karam's trial, where she tried to restrict the radiation to the tumor itself, avoiding the radiation of lymph nodes, is that you get better outcome or impressive outcomes. Mind you, these were not randomized trials, but here it's clear that if you basically ablate the ipsilateral lymph node, you get a worse survival, at least in these animal models. Whereas if you ablate the contralateral node and you keep the ipsilateral node, you get better responses to immunotherapy. So when we do chemoradiation, of course, and when we do surgery, we're ablating basically the tumor, but we're also ablating the draining lymph nodes and all these immune cells. So I think this is something to remember. Fast forward to INVOKE-10, which was also adding a PD-L1 inhibitor, but it added it sequentially with radiation and chemo. So it did not pile up the immunotherapy onto radiation and chemo. And maybe we're heading in the right direction here, because you can see at least that the experimental arm did somewhat better than the placebo. Negative study again, unfortunately, another disappointment, even though we were hoping that this trial would actually be positive. There are several reasons why it could have been, there are several explanations. First of all, it's a small study. The randomization happened after definitive therapy, and so there's a mixed bag of patients. Some of these patients were surgical, some were non-surgical, and so we could go on and on discussing why this trial was negative, but unfortunately it was. And these are the subgroup analysis in INVOKE, and I'm showing you this to impress on you that PD-L1 positive appear to do better, which is a trend we're seeing in many of these studies. But also that despite the fact that there were few patients with HPV positive disease, they tended to somewhat do better with atezolizumab. Of course, we don't know the details on these patients. It's a small number of patients. My question is, were some of these patients surgical patients? Because this trial did not exclude surgical patients. So was it like a post-op atezolizumab that basically led to this improvement? We don't know. I think it's worth exploring this somewhat further. But there are example after example over the last decade, and this is the NRG HN004, where the premise was immunotherapy is likely to be better than single-agent cetuximab because it is improving survival in recurrent metastatic disease over a cetuximab-based regimen, which was the KEYNOTE-048. So let's try to see if durvalumab, again, another PD-L1 inhibitor, would be at least equivalent to cetuximab in this trial. And what you could see here is on every measure, certainly the progression-free survival, which was the primary endpoint, the durvalumab did worse than cetuximab. And so, again, another disappointing study. Local regional failure rate were worse also with durvalumab compared to cetuximab. Mind you, cetuximab performed a little better here than the Bonner trial results. And so again, another phenomenon that we see with more time, these patients seem to do better, whether in the recurrent metastatic setting or in the definitive setting. And so GORTEC is another one of these trials that essentially was the same design and looked at cetuximab and radiation versus pembrolizumab and radiation. Here, a PD-L1 inhibitor. Again, those are patients who are unfit for cisplatin, which was the same for HN004. And you can see that for every measure, again, there was no clear sign that pembrolizumab was performing any better than cetuximab in this setting. Very different results from what we're seeing with the recurrent metastatic patients. And so local regional control was basically the same, progression-free survival and overall survival. So KEYNOTE-412, we could argue, has used pembrolizumab, a drug that clearly has an indication in recurrent metastatic disease, as we all saw. And this trial essentially was similar to the Javelin study, except that it used pembrolizumab instead of avelumab. And you can see a nice separation of the curve. This was a negative trial again, unfortunately. But you can see the separation happening probably a few months after initiation of treatment, indicating that probably the way pembrolizumab is working is as a maintenance agent, really, more so than an agent that is working in concert with radiation or in concert with platinum-based therapy. And when you look and you break down the patterns of failure on the trial, you can see that this probably is the case because most of the differences is seen in distant metastatic disease, 12.9% on the placebo arm, on the pembro arm, versus 16.7%. Of course, small numbers, but not so much difference in local regional progression. And so it seems that pembrolizumab is really producing some benefit in avoiding distant metastatic disease. The encouraging thing in this trial, even though very disappointing overall, is that you did see a trend, a positive trend in event-free survival for the PD-L1 positive group, and you can see a trend here with a median overall event-free survival that was not reached for the pembro and 45.2 months for the placebo. It did not translate very much into an overall survival signal, even though you can see some separation of the curves with longer follow-up. And so those were the lists of negative trials, unfortunately, in the definitive setting. We mentioned all of them. GORTEC REACH is a trial that looked at comparing also cetuximab and to avelumab in the definitive setting. Those were in a platinum ineligible setting, but also there were two cohorts. One included platinum fit and one unfit, and both of them did not really read out to be positive. So there has been recent interest in looking at sequencing of therapy as a possible contributor to the success of these agents. We talked a little bit about the sequencing in the Javelin trial versus the INVOKE 010. This is a small trial from the University of Pittsburgh that looked at local regional control as the primary endpoint and compared sequential treatment, in other words, pembrolizumab maintenance following chemoradiation versus concurrent therapy, in other words, adding the PD-1 inhibitor to the backbone of radiation and chemo. And there's a suggestion here, even though this is a small trial, that the sequential arm did better than the concurrent arm. So that translated into a trend in improved progression-free survival and overall survival that were not statistically significant, but certainly local regional control appears to be favoring the sequential arm. Unfortunately, INVOKE was negative, so that did not pan out. However, at ECOG, we are continuing to enroll on ECOG 3161, which is a trial that also uses the same principle of sequential. However, randomization, unlike INVOKE, is happening at study entry, which is before the platinum radiation. And so we probably think we have a better handle on controlling the data before the nivolumab maintenance. And the trial essentially allows crossover to nivolumab for patients on observation who progress within the first 6 months. It's gonna take a while before this trial reads. What's a characteristic of this trial is that it is solely in HPV positive intermediate risk patients. So we're not really attempting here to lump the HPV positive and HPV negative. As you know, all this is those are two biologically different diseases. So I think this is another uniqueness of this study that we look forward to complete and report. So as we saw in the recurrent metastatic setting, we saw successes. Unlike the non-nasopharyngeal carcinoma, successes have not been observed in non-nasopharynx cancer patients in the definitive setting. However, we just had the first definitive immunotherapy trial report as positive in nasopharynx cancer, with the paper appearing just 2 days ago. For those of you who are interested in reading it, this is a trial that builds up on the sequential therapy that is now considered, or has been considered, the standard of care since the Zhang paper was published in New England Journal of Medicine in 2019, which compared concurrent cis and radiation to sequential gem-cis or gem-carbo followed by concurrent therapy, and showing that the sequential approach is actually superior to the concurrent approach. So this trial, the Continuum study, piled up on this information and added sintilimab, which is another PD-1 inhibitor, first in the induction phase before radiation, and then continued with sintilimab during radiation for a total of 12 cycles, so a little bit of maintenance here, versus the standard, which is sequential therapy and observation. There was no placebo in this trial. And sure enough, the trial read as positive and reached its primary endpoint, which is event-free survival at 3 years, which was statistically significantly improved with the sintilimab arm. One critique is that the control arm on this trial was inferior to the sequential arm that we saw in the definitive trial published in 2019. However, this trial actually excluded patients with low-stage disease, given that this is an immunotherapy trial, and the intention was to, include patients with higher risk for recurrence. Of course, that could be a critique for the study as well. And so again, we've had some advances in nasopharynx cancer. We hope that we will see advances in non-nasopharynx cancer. We could talk about why is it that the first trial in the definitive setting, the first positive trial, was really in a nasopharynx situation and not in another mucosal trials. And I think we could debate that the biology is different, but I think there could be also some effect of sequencing, which, as we all know, we were stuck with cis radiation in the definitive setting for head and neck cancer for the past 25 years. In nasopharynx cancer, that was not the case. I just gave you an example of how sequential therapy progressed to become a standard, whereas our sequential trials in non-nasopharynx tumors essentially all failed, whether the DECIDE or PARADIGM trial. They were big disappointments. And so I think we have not really been able to move the needle towards sequential therapy. And maybe that is one reason why when you pile or when you add immunotherapy to a sequential approach, you're getting an improved outcome. We should learn from this, I think, and we should think about, how to implement immunotherapy maybe in the non-nasopharynx cancer from looking at these results here. And by the way, there are other trials that will be reported, I think some of them at this ASCO meeting as well, in terms of positive trials like this one here in nasopharynx. So moving on, so the news is not all grim, all right? So we may have, we may be on the verge of changing the standard of care very shortly within the next year because there is a new class of agents that we're all waiting for to read on a large phase 3 trial that would be definitive, and those are inhibitors of apoptosis. And those drugs, including xevinapant, which you see here, basically inhibit the inhibitors. In other words, the inhibitors of apoptosis would lead to increased survival of tumor cells, and you're inhibiting those through a mitochondrial-based mechanism. There is also some evidence that these agents could have some immune modulatory effects, especially on dendritic cells and macrophages. But preclinical data essentially showed that they merge or they synergize with radiation and they synergize with platinum. And this phase 2 trial that was reported adding xevinapant to the backbone of cis and IMRT radiation, mostly European trial, and having local regional control as the primary endpoint was impressive in terms of local regional control. And now here I'm showing you the 5-year overall survival, which was a secondary endpoint, but you can see that the xevinapant arm performed very well, and the overall survival was practically doubled at 2 years from 28% to 53%. Some argument that the control arm may have underperformed even in an HPV negative setting. However, we're all waiting for the phase 3 trial, which is a TrilynX study, and we probably should hear about this trial within the next year or so. Now, I'm going to jump very quickly to immunotherapy in the neoadjuvant setting. There is a growing body of evidence, as we heard earlier, about using these agents. There's about 9 preoperative trials. I would say the common theme is that this is safe, does not delay surgery, and this is an example of one study that was published by Ravi Upaduri. You can see the clinical responses and radiologic responses in these patients. Further analysis in another trial by Tricia Weiss-Draper showed that the improvement is impressive in intermediate risk pathologic patients. However, when you go to high risk, the improvement is not such great. You don't see a great improvement. So that raises the question whether maybe addition of chemotherapy may be useful. This is a trial of pembrolizumab with chemo in resectable disease, and this trial revealed impressive response rate, similar to the case we were presenting, overall response rate of 89% with a pathologic response rate of 55%. An example of a trial we completed at Emory is basically a trial using different agents here, immunotherapeutic agents, including pepinimab, which is a SEMA4D inhibitor that we believe modulates the tumor microenvironment in favor of positive response. There is another trial we're also waiting for, the Keynote 689, which is a phase 3 trial of pembro in the pre-op setting, and this trial could very well change the standard of care as well. And so we're eager to know the results of this. This is now a trial that is not just powered for the overall population, but is also powered for the PD-L1 positive with the primary endpoint of event-free survival. To finish, we would summarize this section by saying the spectrum of immunotherapeutic applications in the neoadjuvant setting is extremely promising in head and neck cancer. And I would add, not just extremely promising, but extremely urgent to establish for many of these patients. The cellular machinery, including PD-1 stem-like CD8 T cells, as we shown in HPV-positive disease, but also probably in other diseases, HPV-negative, is there, and we need to bank on this, not really ablate these cells when we try to add immunotherapeutic agents. Now we know this after a painful experience that I just showed you. Relying on this machinery is therefore attractive. And in certain cases, it's safe to say that tailoring your treatment to patients' needs through the use of neoadjuvant immunotherapy-based combinations may be a feasible option. So I would say, if you're not sure, please pick up the phone, call your head and neck expert in your area, because this is a difficult disease, and a disease that you may not see in your local clinics very much. And so I think important to keep the communications open and hopefully look forward to future trials that will improve patient care. Thank you.
Okay. Now, a lot of questions have come in on the through the portal, and so I'm going to throw a few of these out to the panel here, and I'm going to start with and maybe RT, I'll ask you about this one. If you start a patient with recurrent metastatic head and neck cancer on a single agent PD-1 inhibitor, can you then add chemo but continue the inhibitor if responses are suboptimal? And I'm going to ask you to maybe start by speculating what the person might mean by suboptimal response, and then what you would do.
Yeah, definitely. That's something we all do a lot. Like your response rates with single agent pembrolizumab in the first line setting is 20% at best, unless it's a PD-L1 high patient, in which case it will be higher. For those that don't respond at the first scan, suboptimal response really means either they're developing symptoms which weren't there before, or the pace of disease is picked up. It's you see larger tumors, you think there's going to be imminent risk of symptom development. It's very reasonable to add chemotherapy at that point. And that's something I think we all do in practice.
Yeah, I do agree with that. And I think I do tend to also bank on the taxanes in these cases, especially if patients have not had a taxane. I do agree with that.
But I guess maybe we need to do a trial, though, because there are prospective data that show that it's right to continue the PD-1 inhibitor.
And we've never gotten to do such a trial, even though we talked about it. Anyways, that's another discussion.
Here's a question that maybe I'll try to field. Are the risks the same for traditional tobacco use compared with vaping for head and neck cancer? And I think that we have to say that those data are not available yet, and widespread vaping, maybe we're still in the lead time to seeing what the cancers are. But I will tell you, I have a colleague in the pathology department at Yale who has a very expensive device that allows him to vape mice. And there are a couple observations. One is that if he exposes the mice to alcohol and vape and 4-NQO, the median time to a tumor developing is 28 days, whereas many mouse models, we're used to watching these animals for 6-7 months. That's number one. And number two is he's shown both in head and neck and breast cancer that the rate of lung metastases is astronomically increased by vape. And it appears as if many of the more alcohol and aldehyde-based components of the vape liquid, when it's broken down by heat, have very profound immunosuppressive effects. And so I'm quite worried, actually, that we're going to be hit with a tsunami of vape-associated cancers. I don't know if either of you knows of more literature in that space. I think it's a little too early, but...
Yeah, it is. But I would just remind people of the history of smoking, and we never knew about it until it was pretty much decades later. So, I think it's a valid question. And
Nabil, I'll ask you to take this one. Beyond CPS, are there any other promising biomarker candidates to pick either current IO or IO combinations that are on the horizon?
Yeah, the two markers that have been really looked at in head and neck are CPS or PD-L1 and tumor mutation burden. And, you look at tumor mutation burden, the data is not very convincing, at least in the phase 3 trials that we've had. So really we're, as far as, immune markers in tissue, CPS seems to be the only guide that we currently have. However, clinically, we can talk certainly about many other. I look at HPV exactly as you said, Barbara, which is should we use chemo early in these patients? And I think I look at the nasopharynx data and I see that those are two virally mediated diseases where this is working. And I think I tend to outside of a trial think twice before not giving chemo to an HPV positive patient.
Here's a question from Charles. Is extreme completely inappropriate in modern care, or does it still have a role? RT, anybody you still use it in?
So we definitely use it for patients who are PD-L1 CPS less than 1. As you saw with the subgroup analysis, those patients tend to have better OS with an extreme type of regimen versus pembrolizumab-based regimens. And then also for patients who have contraindications to immunotherapy. So, transplant recipients, severe autoimmune baseline disease, those are patients you might want to consider extreme and first up front.
Do you want to mention your ECOG trial, Artie? Because this is, well, I mean, it's not exactly extreme, but it's chemo, Cetux as one arm.
Yeah. So, because we see cetuximab doing so well post-immunotherapy, I mean, we saw that in the Interlink trial, which was with monalizumab and cetuximab versus cetuximab placebo. In the post-IO setting, cetuximab has higher response rates, even up to 25%. So there is something to be said about an extreme type of regimen. So chemo with cetuximab in the PD-L1, in the anti-PD-1 progressor. There is an ECOG cooperative group trial that is enrolling exactly that population. So patients who've progressed on first-line immunotherapy, and it addresses that question of what is best in the second-line setting. Where the control arm is an extreme type of regimen. So it's a platinum doublet with cetuximab. And the trial also attempts to answer the question, can targeting hypoxia with a VEGF inhibitor improve or restore responses to immunotherapy? So the other two arms incorporate chemo with bevacizumab and bevacizumab and atezolizumab. So that's an ongoing trial enrolling nationwide, answering a similar question. Thinking of it.
Great.
Wonderful. Thank you both. This was a great discussion. Thanks to all of you for coming out on a rainy night with some of the worst taxi lines in many an ASCO. And we wish you all a great meeting. Thanks for coming.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Head and Neck Cancer Alliance. This activity is supported by educational grants from AVEO Pharmaceuticals Incorporated, Coherus BioSciences Incorporated, and Merck Co Incorporated.